Makuyu, mute your microphone, please. Everybody who was not muted, mute your microphones. Masinde, mute your microphone. And everybody should log in with their official registration numbers. Fine, I think we will be able to start. If you are not able to hear me, please, the class rep can put it in the chat. If you're not able to hear me clearly, put it in the chat. We have dealt with the respiratory system in terms of the histology from the nasal cavity all the way to the lungs to the alveoli. That is the respiratory passageway where gases pass, they are conditioned, and then there is absorption of oxygen and the elimination of carbon dioxide in the alveoli. We also looked at the non-respiratory functions of the lung. We mentioned the respiratory functions of the lung. Whoever has not muted their microphones, please mute your microphones. So today we are going to look briefly at the development of the respiratory system. After that, we'll have practicals for physiotherapy and also physiotherapy and dental group today. Before we look at the development of the respiratory system, we know that the respiratory system, the nasal cavity or nose, forms part of the face. So let's just mention about the development of the face. The development of the face usually comes from 5 prominences, and these prominences are elevations mainly of the mesenchyme tissue below the ectoderm. These 5 prominences are the frontal prominence, and the frontal prominence gives rise to the glabella. The glabella is the part of the face just above your eye, the nasal bridge, where you have the tip of the nose, all that comes from the frontal prominence. Then we have a medial and lateral nasal swellings. So there are two paired normally, medial and lateral. The medial nasal swelling, I'm just summarizing, then we go to the details, usually will develop to form the nasal septum and develops also ventrally and expands ventrally to form intermaxillary process. This intermaxillary process is between the maxillary prominence of the face. There are usually two maxillary prominences. So between these, we have the intermaxillary prominence or process formed by fusion of both medial nasal processes. This ultimately, the intermaxillary process, ultimately divides or develop to form the philtrum of the nose. Philtrum, just the philtrum is a part of the lip at the midline of the lip. The depression there is what we refer to as the philtrum. That is the formation formed from the intermaxillary process. The most ventral part of that intermaxillary process also forms the primary palate. The primary palate. And this primary palate, eventually in the adult, will be the site for the insertion of the four incisors. Then we have the lateral nasal process, and the lateral nasal process forms the ala of the nose. Just lateral to the bridge of the nose, we have the ala, the flat part of the nose. That is formed by the lateral nasal process. And the other prominence, which is very big, is the maxillary process or maxillary prominence. The maxillary prominence forms the upper lip and also the maxillary bone. The upper lip and the maxillary bone are all formed from the maxillary process. Apart from this, the medial part of the maxillary process also forms the lateral wall of the nasal cavity. The lateral wall of the nasal cavity. From this lateral wall of the nasal cavity, the maxillary process develops some projections into the nasal cavity that eventually form the concha. Now, apart from this, the maxillary process usually grows some medial extensions, which initially are vertical. These vertical extensions we refer to as vertical palatal shelves. Palatal shelves. These arise between the tongue. They arise between the tongue, and sometimes in the 8th week, they raise up. The palatal processes raise up and fuse together to form the secondary palate. To form the secondary palate. So you can see that the palate develops from two parts. The primary palate forms from the intermaxillary process, part of the medial nasal process. And then the secondary palate forms from the maxillary process as the medial projections from the maxillary process. In between the lateral nasal process and the maxillary process, where the two meet, we normally have a groove. And this groove we refer to as nasomaxillary groove or nasolacrimal, nasomaxillary groove. This groove deepens when the two bones, when the two prominences eventually grow up, and the epithelial lining is buried in between these nasomaxillary processes. It eventually undergoes canalization. So we have an epithelial buried which undergoes canalization. And after undergoing canalization, it forms the nasolacrimal duct and also nasolacrimal sac, part of the nasolacrimal sac. And this duct and the sac join up with the nasal sac during the 7th week. The mandibular prominence usually developed from the mandible, the lower lips, mandible and the lower lips. So the two of them fuse together at the mental process, forming the mental process at the symphysis menti. So the two mandibles are completely separate but fused together at the symphysis menti. Apart from this, in order to allow the vertical palatal shelves and lowering of the tongue, we have the mandible also developing. The process of the mandible develops, lengthens, and therefore lowers the mandible so that the jaw becomes lower as compared to its original position. So that is about the fate of the facial prominences. These facial prominences arise from migration of the neurocrest cells. Neurocrest cells usually develop between the neural tube and the surface ectoderm. So those cells detach when the neural tube is completely formed and they migrate outwards. So the prominences are mesenchymal cells that develop from the neurocrest cells. Of the frontonasal prominence, and the frontonasal prominence originates from the neurocrest cells that arise from the forebrain and the midbrain. Forebrain and the midbrain. This part is a maxillary process. They are paired. Frontonasal process is just a single one. Maxillary process are paired. So the maxillary process or processes usually together with the mandibular the hindgut development of the hindgut. In between both the maxillary process, the mandibular process, and the frontonasal process, we have this depression which we refer to as the stomodium. And the stomodium is where we have no mesoderm, only ectoderm and endoderm, forming the stomodium. And that stomodium is covered by the oropharyngeal membrane, the oropharyngeal membrane, the mucopharyngeal membrane, which we'll be looking at later when we're looking at the digestive system. So from these processes, we then have from the frontonasal process, we have some thickening of the ectoderm. Thickening of the ectoderm. This thickened part of the ectoderm forms what you refer to as the nasal placode. The nasal placode. The neurocrest cells around the thickened ectoderm, which we have said originate from the forebrain and the midbrain, eventually proliferate so that this thickened ectoderm now undergoes some depression, forming what we refer to as the nasal pit. So we have the formation of the nasal pit. And as the mesenchyme tissue around this nasal pit proliferates, the nasal pit deepens further and migrates more dorsally and posteriorly to form what we refer to as the nasal sac. As the nasal sac. This formation of the nasal sac is also because of the growth of the frontonasal process forward. The growth of the frontonasal process forward. Around the nasal pit, and then eventually the nasal sac, we have the two ectodermal, mesodermal proliferation the mesenchyme tissue from the neurochroid cells, forming two processes, the lateral nasal process and the medial nasal process. The medial nasal process proliferate faster and fuse together at the midline. This is the area of fusion of the medial nasal processes to form eventually the primary palate, what we have here, the intermaxillary process that forms the primary palate and the philtrum of the nose, the philtrum of the lips, or the philtrum of the lips, and of course, part of it forming the lips. Then we have eventually complete formation where we have the medial nasal swelling and the lateral nasal swelling, with the nasal pit deepening, eventually forming the nasal sac. So from the nasal plateau, we have the formation of the nasal sac, nasal pit, then nasal sac. And then from the intermaxillary process, we have the formation of the philtrum between the lips. The upper part of the upper lip is formed from the medial nasal process, and also the intermaxillary process that forms the primary palate. Now, the two intermaxillary process also extend more posteriorly to form the nasal septum, the anterior part of the nasal septum, so that the two sacs are completely separated by a nasal septum. The nasal sacs, I've said, deepen further because of proliferation of the frontonasal process, and eventually are only separated from the oral cavity, the pharynx, separated from the pharynx by a membrane. That membrane we refer to as the nasal or oronasal membrane. Oronasal membrane. This oronasal membrane initially is a very thick structure that sometimes is referred to as oronasal film, and this thick structure, within the thick wall, it undergoes vacuolization. There are vacuoles developing. These vacuoles coalesce, and eventually the whole membrane becomes very thin, and that is how the oronasal membrane is developed. The oronasal membrane eventually degenerates by the 7th week, and when it degenerates, there's complete opening now of the two nostrils into a common opening that we refer to as the primary choana, choana, primary choana. So the primary choana opens directly posterior to the primary palate, posterior to the primary palate. But we had also the lateral, from the maxillary process, we had the lateral growth towards the midline from the maxillary process, which were initially vertical, but eventually are raised up and becomes horizontal. This we refer to as the palatal shelves. This is what we call the palatal shelf. And when these two palatal shelves meet, eventually they fuse together at the midline, forming the secondary palate. Where the primary palate and the secondary palate meet, that is where we have a foramen in the bone that we refer to as foramen incisivum. Foramen incisivum. So the most posterior part of the palate is soft tissue, and that soft tissue forms the soft palate, and the mesenchyme there differentiate to form the muscles. So that's in a nutshell how the nasal cavity is formed. So the proliferation of the epithelial lining of the nasal sac, both ventrally and dorsally and laterally, and continue on to form the nasopharynx. Continue on to extend to the nasopharynx. So after the formation of the secondary palate, the opening of the nasal cavity now into the common part, we refer to that as the secondary choana. So we have a primary choana and secondary choana, which eventually forms the oropharynx. The nasopharynx forms the nasopharynx. This is an illustration of what we have as the development of the nose. We have the medial and lateral nasal swellings, medial swelling and lateral nasal swelling. We have the formation of the pit. After this formation of the pit, the medial nasal swellings develop to form the intermaxillary process. This intermaxillary process forms the primary palate, and the pit extends further to, this is the oral cavity, the pit extends further to form the sac, the nasal sac. So this nasal sac extends and is separated from the oral cavity by the membrane here that we are referring to as the oronasal membrane. And this membrane is what we say eventually degenerates, and there's continuity between the nasal sac posterior to the primary palate. And that's what we are calling the choana. So the primary choana, that's the part that we have the opening of what is the oral cavity and also the nasal cavity. That's a primary choana. But at this stage, we do not have the formation of the secondary palate. The secondary palate. And like I've said, the medial part of the maxillary process then grows some extension towards the midline. Initially, they are vertical, then they move through 90 degrees to a horizontal position. So they raise up to a horizontal position above the tongue. Initially, they are lateral to the tongue, the palatal shelves, and then they raise up to rise above the tongue, and they fuse at the midline. So that's what's going to form the hard palate. What can go wrong during this process? One, we might have inadequate neurocrest cells forming the medial nasal swelling. The medial nasal swelling. In that case, we will not have fusion at the midline to form the intermaxillary process. So the philtrum, our lips, the upper lip, there'll be a cleft in the upper lip. So there'll be a cleft in the upper lip, which might also extend to the primary palate. The primary palate, the anterior part of the palate might be having a cleft. So we have a cleft lip and a cleft palate. If the maxillary process prominence, the palatal shelves, do not grow adequately towards the midline and also fuse, then we will have also a cleft in the hard palate, the part of the hard palate. So we have a cleft palate, we can have a cleft lip and a cleft palate. So that's what we have as part of the problems that we might have. Another problem that can arise, a congenital malformation, is failure of the oronasal membrane to disintegrate completely. If this failure of oronasal membrane to disintegrate completely, then we have choanal atresia. Choanal atresia. So that again will obstruct airflow into the nasal cavity. So those are the problems that can arise as a result of failure of neurocrest cells to migrate adequately and develop within the processes that form the face, both frontonasal process, maxillary process, and even the mandibular process. If there is a problem with the mandibular process, you might have a jaw which is not very big, micrognathia, very thin jaw. So those are the problems that you might have arising from that. So this is just a summary of what we have talked about. Usually the development is from the 4th week to the 10th week. That's when the development of the face develops from one frontonasal prominence, 2 paired maxillary prominences, and 1 paired mandibular prominences. And the origin of the neurocrist cells are from the mid and hindgut, and then origin from the foregut and midgut, in this particular case. In the 5th week, there's enlargement of the maxillary prominence and the appearance of the nasal placode, which I have talked about. Now, the significant thing about this nasal placode is that it also has some sensory nerve endings that eventually develop to form our olfactory epithelia, that form the olfactory epithelia, which we discussed about in the superior concha, posterior part of the superior concha of the nasal cavity. Now, the cribriform plate through which the axons of the olfactory cells pass will be developing both from the frontonasal, both from the mesenchyme tissue of the neurocrist cells, from the frontonasal prominence, and also from the mesenchyme tissue of the original mesoderm of the body. So there's that invagination of the placode, thickened mesenchyme tissue forming the nasal pit, and then formation of medial and lateral nasal swellings. So this occurs, and eventually by the 6th week, vacuolation of the membrane, and by the 7th week, there is formation of the choanal. That is about the face and the nasal cavity. Now remember, from the lateral process, the lateral part of the nasal cavity developed from the maxillary process. The medial part developed from the medial nasal prominence. So the lateral part of the nasal cavity, the maxillary processes, then grow some processes, some invaginations into the nasal cavity. And those invaginations are what we observe as the concha in the nasal cavity. So those form the concha in the nasal cavity. Apart from that, we then have some evagination from the nasal cavity on the lateral part into the developing bones that form the face and the head. So those eventually form the paranasal sinuses. So paranasal sinuses, which are very important in conditioning of air, are outgrowth from the nasal sac, as epithelial evaginations. For the lung development, we need to note a few things. First, in a summary, we have very early, by 28th week, alveoli have already developed. 24th week, surfactant has already been formed, but not adequately. By the 32nd week, adequate surfactant has been formed by type 2 pneumocytes. So by the 32 week, the fetus can actually grow, with some little support. By 24th week, although we have surfactant, but it is inadequate. Surfactant is first observed in the type 2 pneumocytes by the 20th week. So that's usually very early. So for the development of the respiratory system, the tracheobronchial tree, we normally have the embryonic stage, which starts from the 3rd to the 6th week. And remember, during the 3rd to the 6th week, we said at the 4th week, this is where we have now the development of the face. By the 6th week, we are already talking about the nasal sac, the nasal sac. By the 7th week, we are already talking about the opening of the nasal sac into the choana. So that is the first stage, is embryonic stage from 3rd, 6th week. Then you have the maturation phase. Maturation phase can be divided into several areas. When we have the pseudoglandular stage, where the lung looks like simple or like branched tubular glands, lined by simple cuboidal epithelia. So there are tubes lined by simple cuboidal epithelia. This is from the 6th to the 16th week. And during this period, the bronchial tree develops. Then we have the canalicular stage. During this canalicular stage, 16th to 26th week, we have the conducting portion of the respiratory system and also the respiratory units. That is the respiratory bronchial formation. We have respiratory bronchial formation, the ducts formation. Alveola are still not completely developed at that stage. And we also have blood vessels developing. Like we had said, the blood vessels develop and follow the bronchial tree. Then we have the terminal sac stage. At the terminal sac stage, we have expansions, the budding off of gas chambers, the gas chambers, or the gas exchange areas, budding off. That's at the terminal sac stage. And you can note that at week 24, this when we said there is already well-developed formation of the surfactant. So by week 32, there's adequate surfactant for the baby to survive outside the embryo, outside the uterus. So this is what we have as the terminal sac stage. Already, we have alveoli formed, we have type 1 pneumocytes formed, we have type 2 pneumocytes formed, and therefore you can have survival of the fetus. And then we have the alveolar stage. Note that there is here an overlap. From week 32, from week 24, this ends at week 26. This starts at week 24. This ends at week 36. It starts at week 32. So there's an overlap in development because different parts are developing at different stages of development as continual expansion of the lung continue. And finally, by the 8th week, this is when we now have complete development of the alveoli, the 300 million alveoli we talked about by the 8th year. That's when we have complete development. So here we have more expansion, more budding off, and we're going to see why does it bud off more at this stage. So let's look at each of these phases and see what happens during each of the stages. So remember, embryonic stage, pseudoglandular stage that looks like a gland, canalicular stage where we have more ducts, terminal sac stage, and the alveolar stage. The entire development of the epithelial lining of the respiratory tract is from the endoderm of the foregut. It develops from the endoderm of the foregut. And if you remember your embryology, the endoderm, usually the embryo is divided into the trilaminar embryo, where we have the ectoderm, we have the endoderm, we have the mesoderm comprising of the intermediate mesoderm, paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm. Now, the lateral plate mesoderm is divided into two parts, where we have the somatic part next to the ectoderm that develops to form the body wall So this will develop to form the thoracic cage, the outer part of the thorax, the outer part of the abdomen. Then we have the splanchnic part of the mesoderm that is very close to the endoderm. And the splanchnic part of the mesoderm eventually forms the wall of the viscera, the organs in the thoracic cavity, the organs in the abdominal cavity. But the lining of the respiratory system is derived from the endoderm only. The rest of the wall of the respiratory system, that includes the lamina propria, the mucosa, and all the adventitia, the cartilaginous part, all that come from the splanchnic part of the lateral plate mesoderm. So the endoderm is growing into this splanchnic part. We need to bear that in mind. In between that, we have this space. This is what we are calling the coelomic cavity. So coelomic cavity, we are going to see the coelomic cavity eventually in the thoracic part develops to form the pericardial cavity and the pleural cavity. So at the embryonic stage, at the laryngeal orifice bordered by epiglottic and arachnoid swellings between the fourth and the sixth pharyngeal arches. We are going to look at pharyngeal arches later, but between the fourth and the sixth pharyngeal arches, on the ventral part, we have development and evagination of the endoderm. Evagination of the endoderm. And this evagination of the endoderm eventually forms a ventral lung bud, or what you call laryngotracheal bud. This is the formation of a lung bud. This lung bud formed from the foregut is usually induced so that it does not develop on the dorsal part, but more on the ventral part by both Wnt genes and beta catenin, and there is also expression of NKX2.1, which we will see later on is also associated with the development of the heart. Then we have the tracheal fold. So this is a common depression. From this common depression of the laryngotracheal bud, we have a septum developing from both sides and separating this space into two. We have the dorsal part of this depression that eventually forms the esophagus, and we have the ventral part that forms both the trachea and the esophagus. The ventral part, that forms the trachea and eventually the lung bud. So during this stage, we might also have problems in terms of growth of the tracheoesophageal fold. So failure of the tracheoesophageal fold to develop adequately and fuse to form the septum will lead to tracheoesophageal fistula. That is a hole connecting the trachea and the esophagus. This is a congenital malformation we'll be looking at later. We then have the fibroblast growth factor 10, which is very important in branching and bifurcation of the lung bud. So at the fourth week, this endoderm is growing into the splanchnic mesoderm, like I have said. So that is what completes in the early development of the embryonic stage of development. Then we have the canalicular stage. Well, still embryonic stage, sorry. During this stage, this just to illustrate what we have this development of the lung bud eventually expanding, and it's attached very closely, it's pushing this splanchnic mesoderm towards the somatic part of the mesoderm. This is just what we want to illustrate. Apart from this, we have the growth of the membrane that eventually forms the pleura. The growth of the membrane that forms the pleura. We have the pleuropericardial fold that eventually divides the space so that we have the pleural cavity and also the pericardial cavity. Pleural cavity and the pericardial cavity from the by the 5th week, we have asymmetric division of this lung bud. Asymmetric division of the lung bud, where on the left we have 2 buds forming, and on the right we have 3 buds forming. So that on the left, the 2 buds will form 2 lobes, and on the right we have 3 lobes of the lung. At the 6th week, we have further divisions of the buds on the left and the right to form the tertiary and segmental bronchi. And this forms by the 6th week what we call bronchopulmonary segments. And these bronchopulmonary segments are 10 on the right lung and 10 on the left lung. 10 on the right lung, 10 on the left lung. Each of these bronchopulmonary segments is separated by a thin connective tissue. Separated by a thin connective tissue developed from the splanchnic mesoderm. And this thin connective tissue ensures that surgical operations can actually be done to remove a bronchopulmonary segment if it is affected. You will learn that about in gross anatomy. And this is extending into pleuropericardial space, and we have talked about it as separation of the coelomic cavity into pleural cavity and then pericardial cavity. Pleural cavity and pericardial cavity. Now, the pleuropericardial fold extends and fuses with the septum transversum. So when they fuse with the septum transversum, they completely separate. They fuse with the septum transversum, completely separating both the thoracic cavity from the abdominal cavity. So this is just an illustration. By the 5th week, we have on the right the 2 lung buds forming, on the left, and the 3 lung buds on the right, 2 lung buds on the left. By the 6th week, there is formation of bronchopulmonary segments, both on the right and the left, eventually forming 10-10. And by the 8th week, you can note that the bronchopulmonary segments will have connective tissue. So we have the 2 lobes on the right, 3 lobes on the left, 2 lobes on the right, 3 lobes on the left, 3 lobes on the right, 2 lobes on the left, separated by connective tissue. And remember, this is pushing the mesenchyme. The endoderm lining is surrounded by the mesenchyme that eventually developed from the connective tissue. Now, at the pseudoglandular stage, when we look at these micrographs, we know that they look like tubular glands, very nice tubular glands, lined by simple cuboidal that eventually become columnar and pseudostratified. There are few of these tubular structures and a lot of connective tissue, a lot of mesenchyme tissue from the splanchnic mesoderm. At this stage, the lung looks like a gland, a tubular gland. So we refer to this as pseudoglandular stage. So we have lining, cuboidal to columnar epithelia, and then we have the mesenchyme tissue surrounding it. It then undergoes several generations of divisions. By 20 generations of divisions, we have what we refer to as branching morphogenesis. This continues on up to the terminal bronchiole. We noted that the terminal bronchiole before is actually the end of the conducting system or conducting division of the respiratory system. So we have dichotomous divisions up to 20 generations, and at each branching, we have formation of a blood vessel that supplies that branch. Formation of a blood vessel that supplies that branch, and a blood vessel that drains that branch. That's why we form the bronchopulmonary tree, and the blood vessel mimics the bronchopulmonary tree. And then eventually in the pseudoglandular, the distal parts will form the respiratory bronchiole. The epithelial lining, which was simple cuboidal, now differentiates and forms eventually respiratory epithelia, which we talked about. And just to mention again, the mesenchyme tissue, mesenchyme cells, surrounding the dividing bronchial tree differentiates to form the blood vessels, the cartilages, the elastic tissue, the connective tissue that surround the bronchi and eventually surround the alveoli. So this is our pseudoglandular stage. Pseudoglandular stage is where to have the esophagus. This is the trachea, also differentiating eventually. And you can note that we have almost gland-like structures with a lot of mesenchyme tissue. So very small ducts, that's why it's called canaliculi. Canaliculi are very small ducts. So we have very small channels formed by this branching morphogenesis. Sometimes we have problems in terms of branching morphogenesis because of fibroblast growth factor 10 inadequacy, so that we do not have adequate formation of the alveoli eventually. The number of branches will not be adequately formed, and that is a congenital malformation. So at this canalicular stage, we have elongation and branching of the terminal bronchiole to form pulmonary acini. Pulmonary acini. You remember pulmonary acini? The functional unit of the lung. That is formed at the canalicular stage. And then the connective tissue around it eventually reduces. The number of blood vessels increase. There's more blood vessel formation by the process of vasculogenesis, angiogenesis, sorry. And then we also have towards the distal parts, the epithelia thins out now to differentiate into the pneumocyte cells, type 1, type 2 pneumocytes, and also the other bronchiolar cells that we talked about. Then by the 20th week, we have said the secretion of the surfactant, lamellar bodies are observed in the type 2 pneumocyte, but they are not adequately produced until about 24th week of development. So this is just to show that this is cuboidal epithelia lining the canals. There's a reduced mesenchyme between the epithelial lining, and towards the distal part, this cuboidal epithelia thins out to eventually form the type 1 and type 2 pneumocytes, and then the Clara cells. If you remember, at the level of the terminal bronchiole and also respiratory bronchiole, we had cuboidal epithelia. But proximally, the epithelia becomes pseudostratified. Then we have the terminal sac stage, which you talked about, and the terminal sac stage is more of expansion of the distal parts, expansion of the distal parts, reduction in the mesenchyme tissue, formation of more blood vessels, and in this case, we actually have a double-layered blood vessel. So each of the alveoli will have double layers of blood vessel, but this eventually thins out so that you only have a single layer towards the end of the terminal sac stage. So this increased angiogenesis, more blood vessels, formation between the septa, and also more thinning out of the cells to form type 1 and type 2 pneumocyte. And by week 32, we have now steady and adequate formation of surfactant. And how do we know that this maturation of the lung? By looking at the lecithin sphingomyelin ratio, which is supposed to be 2:1, indicating that the lung is mature. So at this stage, we'll be having almost a mature lung, and therefore the fetus can survive outside the womb. So alveolar stage is more establishment of blood vessels and also bulging out of alveoli. This bulging out of alveoli is forming something like circules. What is very important during this stage is actually elastin synthesis and collagen synthesis. It is noted that elastic fibers, elastin synthesis, seem to be at the position of the budding off. So it induces the budding off so that we have more and more alveoli formation. And this continue on. And there's very rapid development by the third year. Rapid development by the third year, but we have said the lung completely develops up to the 8th year. So the alveoli increase from 100 million at birth to up to 300 million in the adults. But very rapid division formation during the third year. So you can note how the lung develops. So this is how the lung develops. And we have noted that we can have malformations, congenital malformations, at any time during this development of the lung. Now, let's look at some congenital malformations. What can happen? What can go wrong? We have talked about the nose. In the nose, we have said when you have inadequate neurocrest cells migrating to the frontonasal, maxillary, and mandibular processes, then you can have defects. You can have defects. When you have medial nasal swelling that is created by rapid proliferation of the neurocrest cells around the nasal placode, if the medial nasal swelling does not develop adequately, then we have a cleft in the lip because the philtrum is formed from the medial nasal swelling. Fusion of the two medial nasal swellings, eventually. The intermaxillary sinus, intermaxillary process, which forms the primary palate, is also formed by fusion of the medial nasal swellings and expansion of the intermaxillary process. Failure of this can lead to a cleft palate, anterior cleft palate. Failure of the lateral process growth of the palatal shells from the maxillary process can also lead failure of fusion of the two because of inadequate neurocrest cells, can also lead to a cleft palate, posterior part of the cleft palate, and a combination of posterior, anterior, and the lip can be able to form. Failure of canalization of the ectodermal cells that have been buried between the lateral nasal swelling and also the maxillary process in the nasolacrimal groove. Failure of that can lead to blockage of the nasolacrimal duct. Remember, the nasolacrimal duct opens into the inferior meatus of the nasal cavity. Failure of the oronasal membrane to disintegrate completely can lead to atresia of the choana, so choanal atresia. within the larynx. We also have the posterior part of the larynx. Sometimes failure of canalization of this can lead to membrane, parts of the membrane might remain. As you enter into the larynx, this can also lead to atresia, and also laryngeal waves can form. Failure of tracheoesophageal septum to develop and separate the common laryngotracheal bud into the dorsal part that forms the esophagus and ventral part that forms the laryngotracheal tree. Failure of that to form eventually will lead to tracheoesophageal fistula. And we'll look at different conditions of that. Failure of the pluripericardial fold to fuse together with the septum transversum, eventually, and failure of the septum transversum might lead to discontinuity between the thoracic cavity and the abdominal cavity. That forms, and organs from the abdominal cavity can enter into the thoracic cavity, forming the diaphragmatic hernia, congenital diaphragmatic hernia. And when this occurs, you then have inadequate space for the expansion of the lung as the lung proliferates. So where we have the hernia, that side will have hypoplasia of the lung. It will not completely develop. It will be underdeveloped lung. Failure of the lung bud to form. We normally have two lung buds before they divide in the fifth week into three on the right and two on the left. Failure of the lung bud to form can lead to failure of development of the lung. That we refer to as lung agenesis. The lung does not develop. That is lung agenesis. Bilateral lung agenesis is not compatible with life. So you can only have, if one lung fails, lung bud, the other one can still expand and the child might be born alive. We have formation of the surfactant, which is supposed to reduce surface tension and therefore maintain the patency of the alveoli to stop alveoli from collapsing. So when the child is born and breathes in, the alveoli expand. It's like you're blowing in a soap bubble. So failure of inadequate production of surfactant can lead also to respiratory distress. Respiratory distress at birth. Sometimes there might be damage to the alveoli, damage to the blood vessels, and there is leakage of plasma into the alveoli in the fetus. When that happens, leakage of plasma, the fibrin, together with the damaged cells, will line the inner part of the alveoli. When they line the inner part of the alveoli, they make a membrane-like structure in the inner part of the alveoli. That we refer to as the hyaline membrane disease. So hyaline membrane disease, it means that when the child breathes in immediately after birth, there'll be problems with diffusion of oxygen through this thick membrane formed by cell debris and also formed by protein film from the leaked plasma. So that's hyaline membrane disease. So these are some of the congenital malformations that we have. And let's just look at this one here. Look at this story. A child is born, excessive drooling because cannot swallow saliva. coughing, immediately an attempt is made to feed the child. There's coughing and choking, and the X-ray shows distended stomach with air. What does this tell you? It tells you that there's a connection between the respiratory tract and the digestive tract. What congenital malformation can this be? Here we have what you would call tracheoesophageal fistula. That is how the child presents. Immediately an attempt is made to feed the child chokes, because the food is going into instead of going into the esophagus, it's also going into the trachea. What about this one? A child is born with severe respiratory distress shortly after birth. The child is not breathing. And then the team notes that the child breathes uncomfortably when crying. The child, when he cries, seems to be better, but when the child stops crying, there is a lack of oxygen. What does this mean, lack of oxygen? It means there's a blockage somewhere in the airways. There's a blockage in the airways preventing air from getting to the lungs. And when you pass a soft catheter through the nose, it should go to the pharynx. It should go to the nasopharynx, and eventually it should go to the pharynx and can be trachea or esophagus. What does this mean? There is no connection between the nasal cavity and the pharynx. What can prevent connection in the developing fetus? It is failure of the oronasal membrane to disintegrate completely. So that's what would be the problem. So what we have here is choanal atresia. Remember the choana? Choana is when you have the membrane completely disintegrating, then we have the opening into the posterior part of the primary palate. So choanal atresia is taking place here. That is the anomaly that we have. And these are the signs that take place. This is tested by looking at the catheter not passing through. That means there's no continuity. In normal cases, the catheter should pass through. But why does a child improve when the child cries? When the child is crying, it is forcing air through the nose, but also forcing air through the mouth and breathing through the mouth. So this mouth breathing. So the child gets in air through the mouth into the lung. So because of that, there seems to be some oxygen within the lung. So that is what is happening in this case. What about this one? A newborn is cyanotic with severe respiratory distress shortly after birth. Not getting enough oxygen shortly after birth. Auscultation, if you remember what I talked about before, listening. Auscultation of breath sounds on the left side. When you try to put your stethoscope and listen, you see some vowel sounds on the left side. Vowel sounds. That means there is some intestinal material, intestines that have moved to the thorax. So, what is the most common cause here? This is mainly because of the congenital diaphragmatic hernia. Congenital diaphragmatic hernia. And this congenital diaphragmatic hernia, because the intestines are occupying a space where the lung is supposed to develop, then that lung undergoes hypoplasia. The lung undergoes hypoplasia. It doesn't develop on that side. So here we are talking about congenital diaphragmatic hernia. So these are some of the conditions that we have: respiratory distress syndrome, hyaline membrane disease, some extra lungs because of supernumerary lobes because of division of the lung lobes, and then agenesis, which we talked about, pulmonary hypoplasia, which we talked about, and the phlegmatic hernia, which we talked about, bronchopulmonary dysplasia because of the hernia. Tracheobronchial anomalies can be atresia, stenosis. Now, atresia is narrowing of the passageway. Stenosis also is narrowing of the passageway, and this sometimes can occur because of failure of the blood vessels to develop, but also failure of canalization. Remember, during the development, the entire lumen is almost filled by cells. So these cells, eventually the inner cells, undergo apoptosis so that we have a canal formed. So failure of a canalization can lead to stenosis. Some of these conditions are noted to have common genes. And therefore, when you have any of these conditions, they will also be associated with other conditions. And this is what we refer to as bacterial, where we will also have vertebral malformations, anal malformations, like imperforate anus, cardiac malformations, because usually for the heart, neurochorial cells also are very important. Information of the cardiac chambers, tracheoesophageal fistula, which we talked about, renal malformations, and limb malformations. So this, you note about all this, there's migration of cells. So any genes responsible for the migration of the cells, or morphogenes responsible for this, we have common genes that can, therefore, whenever you have a respiratory distress syndrome, you must check for other abnormalities. When you have a membrane hyaline disease, check for other abnormalities. When you have tracheoesophageal fistula, also check for other abnormalities. That is the message that we need to remember. There is errors in bronchial morphogenesis. Normally, we have induction between endoderm and mesoderm. The mesenchyme cells and also the endoderm, sort of reciprocal induction means each of them influence the other's division, so that the mesoderm can actually induce the endoderm to now separate, so that you can have the budding of the endoderm induced by the mesoderm. The ectoendoderm will now induce that mesoderm, for example, to develop blood vessels and so on. So these are congenital malformations and the development of the respiratory system. Here we are looking at the lung. This one is lung hypoplasia. You can see this lung is normal. This lung is very small because there was a hernia into this part. Which part are you most likely to have a hernia? Is it the right side or the left side? Remember, the right side of the diaphragm is normally associated with the liver. So it's mainly the left side where you have herniation taking place. So whenever you have lung hypoplasia, it will always be the left lung. These are some of the variants of tracheoesophageal fistula. Variants of tracheoesophageal fistula. Here we have the trachea, continuing most distally with the trachea. So here we have the esophagus, not connected distally. Here we have no connection of the esophagus. Here we have esophagus forming something like a K, connected, but an opening to the trachea. So if there's any food taken here, it will enter into the trachea or the bronchi. All the food that's taken here will enter into the trachea, and therefore there'll be choking. This H shape, the food also will be taken into the trachea, so there'll be choking. So these are variants of tracheoesophageal fistula because of failure of tracheoesophageal septum to develop. So in summary, we noted the general functions of the respiratory system. We discussed them. Respiration, which involves inspiration and expiration. Also acid-base balance, which we talked about. Conducting of air, which we talked about, the entire conducting system. Conditioning of air, which we talked about, warming, humidification, and filtration. We also have non-respiratory functions of the lung. One of them is converting inactive angiotensin 1 into angiotensin 2. Angiotensin 1 is formed from angiotensinogen by cleaving by the enzyme renin. So we have angiotensin 2, the endothelial cells of the lung converts angiotensin 1 to angiotensin 2, which in itself regulates pressure, blood pressure. But angiotensin 2 will also act on aldosterone, aldosterone produced by the adrenal gland. This causes reabsorption of sodium in the kidney, and there
Recording in progress.
Well, somebody says mvua inataka kunyesha. I expect everybody to come to the histology lab. If that is your comment. And that is comment is by Techno KJ5. I said everybody must log in with your official registration number. Fine, in the absence of any question, thank you very much. For the nursing group, we are going to organize a practical, most likely tomorrow. We'll organize a practical tomorrow. I've been trying to share the slides. I'll try again. So we'll organize a practical tomorrow for the nursing class. Thank you.